Currently in the United States, approximately 3% of children will be born with a birth defect, and we can group these broadly into three categories, which I'll discuss more in a moment. But these are chromosomal anomalies, known single gene syndromes, and then the third, and by far the largest category, are so-called non-syndromic birth defects. And these birth defects occur in the absence of an identifiable chromosomal or genetic cause. And they include, for example, most cases of some of the common birth defects with which you might be familiar, such as cleft lip and cleft palate, or congenital heart disease. And although we generally think of cancer as a disease of aging, it is in fact the leading cause of disease-related mortality in children as well. It is a fairly rare event in children, as has been pointed out, with a combined incidence of about 18 per 100,000 kids. And for the most part, there are few established risk factors for pediatric cancers. Specific to the context of birth defects, there are some known cancer predisposition syndromes. But for the most part, for children with these non-syndromic birth defects, it's unclear whether they are at increased risk of pediatric cancers, and if so, what the magnitude of that association is. When we consider the set of birth defects that might occur, 6% or so are related to the chromosomal anomalies that I mentioned previously. Probably the best known example of this would be trisomy 21 or Down syndrome, and that condition does confer an increased risk of pediatric leukemias. Another 7 to 8% will be related to a single gene syndrome. A good example of such a syndrome would be Costello syndrome, which predisposes primarily to pediatric rhabdomyosarcoma. But again, the majority of birth defects are non-syndromic, and it's somewhat unclear if these children are at increased risk of pediatric cancer. So there have been some studies which have been performed previously to try to answer just that question. Generally, they've been constrained by their sample size such that they've had to aggregate on one side of the equation or the other. For example, they've looked at the risk of a specific cancer among children who had any birth defect, or at the risk of any cancer among children who had a specific birth defect. Generally, these studies are quite consistent in suggesting that children who have some non-chromosomal birth defect are between 2 and 4 times the risk of childhood cancer compared to a child with no birth defect. But what's missing from them, largely, are good population-based estimates of the risks of specific cancers in association with specific birth defects. And that's because what's needed to answer that question are very large population-based studies that have sufficient numbers of birth defects to allow for estimation of those risks. So this brings us to the GOBACK study, which is the study that I'll be discussing today. GOBACK is an acronym for genetic overlap between anomaly and cancer in kids. And this portion of the study is designed as a registry linkage between birth defects, and cancer registries in 4 US states. And by linking data retrospectively from these registries over a period of years, we were able to form a retrospective birth cohort of more than 10 million live births. So our goal in doing so was to determine specific birth defect childhood cancer associations among children who have these non-chromosomal or non-syndromic birth defects. And the significance of that work is twofold. Firstly, this will help us identify novel cancer predisposition syndromes by informing future research into the etiology of childhood cancers. Secondly, this might potentially help us improve surveillance strategies for childhood cancer in the future by helping us identify cancers at their earliest, most curable stages. Methodologically, as I mentioned, the study was performed by linking individual level records from each of these 3 registries within each of the states, harmonizing the data across the states, and then analyzing the pooled data as a single unit. Depending on the state, data collection began as early as 1992 and continued as recently as 2013. Once we had the data pooled, we computed hazard ratios and 95% confidence intervals using Cox proportional hazards modeling. This allowed us to estimate the risk of childhood cancers in association with particular birth defects, taking into account other factors that might affect the relationship, like the age of the mother, the sex of the child, and the state in which the child was born. In addition, we required that there be at least 5 co-occurring cases of the birth defect and the cancer being considered in order to compute a hazard ratio. And due to the number of tests we performed, we used a procedure known as the Bonferroni-Holm adjustment to account for chance findings. Some quick summary statistics from the cohort. We had approximately 10.1 million live births in the study. Within that group, we were able to identify approximately 540,000 children with a birth defect, about 15,000 children with cancer, and just under 1,800 children with a co-occurring birth defect and cancer. So the first thing we did is we looked at the risk of any childhood cancer among children who had any non-chromosomal birth defect. And similarly to what's been seen before, we found that these children were about 2.5-fold increased risk of any childhood cancer. We next looked at a number of specific birth defect childhood cancer associations, and I'll just highlight a few today. We found, for example, that children with several forms of congenital heart disease, including ventricular septal defects and either right or left ventricular outflow tract defects, were at increased risk of childhood cancer, notably of hepatoblastoma or neuroblastoma, and that the magnitude of the increase in risk ranged from 7-fold to 20-fold, depending on the defect and the cancer being considered. In addition, children with several craniofacial or central nervous system defects, such as craniosynostosis, hydrocephalus, or spina bifida, were in increased risk of cancer. Often, but not exclusively, these associations were with central nervous system tumors, such as ependymoma or astrocytoma. And again, the magnitude of the risk increase is quite large, ranging up to 75 in this case for children with spina bifida and non-rhabdomyosarcoma soft tissue sarcomas. So some considerations that I think we can apply to this study. The unique strength of this study is that it's a very large population-based estimate of these risks, and we were able to look at them in a much more specific way than has previously been possible. But we do have a couple important limitations to bear in mind also. So this is an observational study. It does not establish a causal link between birth defects and childhood cancers. And secondly, we're constrained by a lack of data on the time period between the child's birth and the date of their cancer diagnosis. In the future, we do plan to expand the registry linkage portion to be able to study additional rare associations, rare birth defects and rare cancers. And additionally, we hope to sequence informative families where the child is affected by both a birth defect and a cancer to investigate putative genetic causes of cancer among children with non-chromosomal birth defects. So a couple key conclusions. Children with non-chromosomal birth defects have approximately a 2.5-fold increased risk of any childhood cancer. Additionally, and for the first time, we were able to identify a number of specific non-chromosomal birth defects as being associated with specific childhood cancers, often at magnitudes of association that exceed those that have been reported previously. There is one final caveat that I would add. That's that childhood cancers, as has been mentioned, are rare events. So even though the increases in risk that I present today are pretty dramatic in some instances, do bear in mind that the majority of children who are affected by the birth defects that I referenced today will not, in fact, go on to develop childhood cancer. So let me just finish by acknowledging my mentors, Philip Lupo is the study PI, also Michael Schurier and Sharon Plon, our internal and external collaborators, and the support of our funding sources. I have a poster on this tomorrow if you'd like sort of a more long-form presentation of the results, and I'd be happy to take any of your questions.